Angelo Stefanini. He has a very long-lasting experience from different point of view on public health in low-resource settings. He started as a physician on the field in Uganda and Tanzania, then went back to school to study, to specialize, but also to teach in several universities, in several countries, at the University of Leeds in UK, then Makerere University in Uganda, and then back in Italy at the University of Bologna. He also served as coordinator or head of projects for WHO and also for projects of the Italian ministry in the occupied Palestinian territory. And he's going to give us a keynote lecture on healthcare in low resource settings and medicine of poverty. Angelo, thank you.
Thank you very much. I must say, I really feel like a fish out of water, because probably what I'm going to see may seem far away from what you're going to do. But at least I hope you may get a global context of the work you're going to do in your future. I'm not sure how to regulate to remain within the limits and not to lose my track. I've written down, so I will be reading most of the presentation. First of all, right. My apology to start on a personal note. What you see is a collage of pictures taken during the first years of my work as a medical volunteer, as a tropical doctor in East Africa. Although this experience is something I used to be proud of, this kind of representation may be seen as a particular image of the tropical doctor as a savior, following the ideology of saviorism, which says that there is some people who are saviors and other people who need to be saved by them. In the next 40 minutes or so, I intend to criticize and deconstruct this image by showing how tropical medicine and medicine in the tropics has less to do with geography than with political economy, less with tropical climate, but rather with poverty and inequality. So the outline of my presentation is the following. I will start by talking about tropical medicine in the context of colonization. Then we'll move to describe health policies in low and middle income countries over the years. And we'll focus on hospitals, on the issue of accessibility to healthcare. Then I will enlarge my view, my horizon, to discuss how health improves, to conclude with a call to acknowledge the role of society, the so-called social determinants of health, and not only geography, in producing and destroying health. When more than a century ago, the term tropical medicine was created, the word tropical indicated not only a specific group of diseases, but also, quote unquote, the need for a civilizing force that could defeat them. End of quotes. It is important to remember that the tropics were ideologically invented as well as discovered in their geography in the form of tropical races, of exotic plants and fruits, of frightening diseases like yaws or yellow fever. And in that way, the association of hot and humid diseases and hot and humid climate and diseases typical of the world was born. Medicine was seen first for the protection of the colonial power. A well-known English historian reports that the tropical medicine had the task of, quotes, ensuring the security and improving the productivity of the British Empire, end of quotes. Many missionaries saw health services not only to promote the well-being and development of indigenous people, but also as a fundamental component of their civilizing mission and the tool to convert pagans to Christianity. Medicine functioned in part as an agent of Western expansion. Today, in the health field, it is increasingly difficult to identify conditions that are specifically and exclusively related to climatic or geographical factors, while there is evidence of how the health problems of poor countries depend more on socioeconomic situations. What is increasingly apparent is the need to deconstruct the systems of dominance and power embodied by colonial health, that is to decolonize, that's the new word which is sprouting, coming out in the recent years, decolonization, to decolonize tropical medicine, which some call also global health, but global health to me is something different. In all societies over the span of many generations, there have always been practices that had to do with health and disease, and traditional healers have always played important roles in passing on belief systems linked to local culture. Colonial expansion has actively promoted typically Western views of health and medicine, often in strong opposition to traditional indigenous practices. Although at first the colonial health services had the main purpose of protecting the health of expatriates, especially the military, public officials, and settlers, the need to take care of local population became increasingly evident. With the advent of independence, in most cases, it was the local elites who benefited most from the new policies, though some African governments tried to respond to the needs of populations with policies based on principles of equity and universal access to services. You see the examples of some countries like China, Cuba, Kerala. One of the most significant events for the international health policy was the Alma-Ata conference in 1978. Anybody heard about Alma-Ata conference? One? Okay. Sponsored by WHO and UNICEF, where a radical strategy for health and health services was proposed, identifying primary health care as the key to the attainment of the goal of health for all. However, the socialist rhetoric and the long lead time required by such a strategy were soon attacked by the more pragmatic part of the conservative international medical establishment, backed by financial institutions such as the World Bank, prestigious universities, and major donor organizations, which contrasted WHO's public health comprehensive approach with a biomedical selective approach made up of vertical interventions and measurable short-term outcomes. This conflict marked the beginning of the decline of WHO's leadership. Let's look at some detail. What are the key differences between the primary care strategy proposed by WHO, the comprehensive primary care, and the selective primary care proposed by the medical industrial complex? Sorry, there is a way to remove this. C'è qualcosa qui? Anyway, because it's covering the there is a window covering the, anyway, no problem. The difference is according to these different elements, the different health paradigm. The comprehensive primary care looks at a holistic, health as in a holistic, ecological, salutogenic perspective, while the selective primary care is more biomedical oriented. Health is seen by the comprehensive primary care as a positive well-being, while in the selective primary care is just the absence of disease. The locus of control, who has control on health, according to the comprehensive primary care strategy, are the communities as well as the individuals. Instead are the doctors, of course, who have the control, or should have the control of in the selective perspective, selective strategy. The major focus is that on the comprehensive primary care is health is the result of social justice, equity, and community empowerment, while in the other selective approach, health is due to the medical intervention which treat diseases, specific diseases. The major healthcare providers are multidisciplinary teams according to the comprehensive approach. Of course, the major providers are medical doctors for the selective approach. And the strategy is multi-sectoral collaboration for the comprehensive primary care. And for the selective primary care are just the so-called vertical interventions, targeting just single diseases, one by one. So this was the major divide between the two different views. And I remember during the 80s and the 90s, there was a big discussion, especially in the academia, but also among international organizations, on where to go, which kind of strategy to follow. Of course, the political vacuum in international health policy left by the progressive neglect of WHO, which because of this conflict started to lose his leadership, has been forcefully occupied by other institutions, such as, oddly enough, a bank. The World Bank, in fact, has come to emerge as the dominant force in the international health arena. In his publication, the World Development Report, which you see here, 1993, Investing in Health was the title. This report came out when the health sector, and not only in the global south, the time was ripe to offer itself, the World Bank, to offer itself as a new technical and political guide to the development of the health sector. So all of a sudden, most international health organizations moved their eyes from instead of looking and following WHO lead, started to follow the money of the World Bank. Of course, with the money came also the health policy recipe, which was what? The main topics, the main points of the health policy, World Bank health policy recipe was that government should provide limited health service packages, that hospital care should be paid directly by the patient and not through national health systems or whatever, that other services must be provided by the market and by non-government organizations. The state is left out of business, and money should be spent efficiently. But the trick part of is really on what do you understand by efficiency in healthcare. I'm not going to details on this, but the result was an increase in inequity and misallocation of resources. So to summarize everything, it was recommended by the World Bank had to be facilitated by a political climate where the role of the state was greatly reduced, so-called state minimalism. The development of private sector was favored. The deregulation of the health industry supported, and the financing of health increasingly relying on private insurance and direct payment of services, gradually abandoning the method of financing based on progressive taxation. The world hegemony enjoyed by the bank meant that these fundamental elements of the new health policy soon began to enter the negotiations, generally behind closed doors, that periodically take place between national governments and international organizations for the granting of cheap aids, which meant that the World Bank would put on the table these conditions, in fact, the conditionalities. If you want cheap aid, you have to put in place the policy I dictate to you, which I just listed to you. The hospitals was the main target of the new reform by the World Bank. The main reform called for an increasing autonomy for the hospital, for the so-called corporatization of hospitals, which means the transformation of hospitals into corporations, which led to a monopoly in the healthcare system, resulting in competition between non-profit and for-profit hospitals, leading to an inflation of healthcare prices, which leads to disparities in the proper treatment of individuals. Since their introduction in the 90s, these changes have had strong implications both for healthcare and health, raising questions regarding issues such as equity, control, accountability, and performance in the healthcare sector. The evaluations conducted in recent years on what was a genuine social experiment in low and middle income countries show that the social utility of the hospital is often sacrificed on the altar of the inexorable laws of the market, and the need to improve the allocation of resources between hospitals and non-hospital activities, and between hospitals at different levels of the health system. Since the hospital, that's a major point we have to remember, since the hospitals account for a major part of public sector expenditures, usually more than 50% of the health budget is spent on hospitals in countries, especially in developing poor countries, an improvement in the efficiency of their use of resources can bring enormous benefits to the entire sector. So the issue is the accessibility of healthcare. Just probably many of you knows already this concept, but I would like to underline the importance of access to healthcare as made of different components. There is the physical component, geographical component, which is the accessibility, the availability of the services in the field. The financial component, financial accessibility, the affordability, and then the cultural acceptability, which is most of the time really undervalued and forgotten. It's very important how the patient feels when he enters or she enters the health center or the hospital, how he's treated as a human being, something which the doctors are not trained in. And of course, access is one aspect, which access we can define it as opportunity and freedom to use health services, but unless there is a use, a utilization, the actual utilization of the health services is not enough that the service is accessible. And utilization is defined as the informed decision to exercise the freedom to use healthcare. So let's continue. How to improve the hospital efficiency? The major difficulties in the health sector, in low and middle income countries are largely attributable not only to scarce resources, but perhaps largely to the malfunctioning of the hierarchical organization of the health system. In theory, the lowest services, the health posts in the villages, the local dispensaries, health centers, and small rural hospitals should provide the assistance of primary and preventive type to the population living in a peri-urban and peripheral area. This is where the bulk of the population is and where the demand is greatest. The problem is that is exactly this level that is underfunded, but usually by the state, by the government. While most of the funds are going to the upper levels, to the hospitals. So hospitals in that way are also forced to perform jobs for which they are not, of course, supposed to. The primary services, the preventive services should be provided, as we said, at the local level. And the hospitals are not equipped to provide this, are not good to provide the primary services. So as a consequence, there is a very high because the patients going to the nearest health center don't find the response to their demand, to their health demand, so they go to the hospital, they jump straight to the hospital where they are not treated properly. So there is a high social cost, there is high inequity and inefficiency. So it's very important to meet the need at the different levels of the health system. How do we meet the need of the entire population at the different system at the different levels of the health system. The response is what is called the referral, the so-called referral system. The referral system, which can be defined as the functional link between facilities of varying levels in the healthcare hierarchy. Each level of the hierarchy of the health system have different responsibilities, different kind of allocations, and different kind of also competencies. So when a patient is seen at the primary level and there is no response in terms of capability, in terms of resources and so on, is referred to the higher level. And again, if the higher level is not enough, to the highest level, which is the tertiary level. So the health system is seen as a pyramid with the 3 different levels according to the different specialties. So the objective, the goal, is to provide the best quality care at the most appropriate level of the health system. And what is the best quality care? The right patient, that is the patient diagnosed properly, should be admitted in the right place, that is the place which is capable to provide the response, to give the response needed by the patients, as close to their homes as possible. So let me move to we give it to a broader perspective. Let's start to look at how health improve in order to connect with the previous things I've introduced. If you look at this graph, you will see that this is for the tuberculosis mortality, that in the 20th century, health improvement preceded rather than followed the major medical and scientific discoveries. If you see, completely blackout. If you look at the line and the graph, you will see that the major scientific developments arrived when the tuberculosis mortality was already dropping on its own. You see, the streptomycin, for example, which arrived at the end of the 30s and 40s in the mid-century, arrived when most of the mortality for tuberculosis had already happened. Okay, so this is a demonstration that there was something else which produced this improvement. You may guess what it was. Why do you think tuberculosis mortality dropped before the arrival of antibiotics? It's rather, anyway, because of the improvement of quality of life, improvement of hygiene, improvement of nutrition, improvement of working condition, improvement of all the life over the 19th and 20th century. So the improvement of quality of life, even without, of course, drugs and hospitals and doctors are very important, but you see, they are not the only answer which health needs. So in such a planetary context, and in the face of the recent trends of world health, the discipline of tropical medicine would seem to have a limited relevance. In fact, medicine in the tropics has to do in most cases with the health problems of society, in particular infectious diseases, which in addition to being connected with tropical climates, are above all associated with poverty. In short, as already mentioned, the most urgent problems for poor countries are wider in scope than those that gave rise to the so-called tropical medicine, and largely derive more from the socioeconomic conditions in which the population of those countries find themselves because of political, ecological, and geographical factors. International and national local system of disease control and health services provisions are both determinants. If you see, how many of you have already seen this picture? One, the technician. That's very. Yes, this is a 20 years old picture produced by WHO to show how all the, once we used to call them factors, health factors or health determinants, all the different factors which determines health, put together, starting from the age, sex, for the biological factors, moving out to the lifestyle, out again to the community networks, which are very important to protect health, and all the different sectors in which society could be divided: agriculture, education, work environment, work, whether you have or you don't have work, because unemployment is a very important determinant of health, determinant of disease, if you want. Water and sanitation, and healthcare services. You know, the arrow indicates also healthcare services, which are very important, but they are not the only determinant of health. This was the objective of, the main objective of this picture, to give, to describe to relative, how do you say, to relative, the relativity, how relative is the importance of the health service in respect to the other determinants of health. Okay? Oh, thank you. So the healthcare services, which is actually what we were talking about so far, are very important, and they are very important also not only to protect health, but also to empower people, because if you remember what the comprehensive primary care produced by WHO says, that community participation people are those who should control their own health. This is a very important component of this picture, which shows the different components, the different factors and determinants of health. So the real life, and I'm going to conclude, the real life for what is still called tropical medicine in the 21st century is not about, it's not semantic, it's not about his name, but like for the other health and related professionals in general, wherever they practice, is to make, going back to my title, the pathology of poverty understandable, and show that the growing gap between rich and poor is directly associated with disease and death. This is where we have to go back when we think about how health improves. Health improves when all these factors are present to protect the health of the population in any country, at any different levels, in the tropics, on the Arctic, or in Europe, or in Africa. And I would like to conclude with a sentence by a Swedish academic and an African prime minister some years ago, which were published in the British Medical Journal editorial. As health professionals, we have a responsibility to describe in medical terms what happens when impoverishment takes its toll on the most vulnerable groups in society. We need to make the pathology of poverty understandable and show that the growing gap between the rich and poor is directly associated with disease and death. So, in a way, in a short expression, is how to expose the process and the mechanism of what is called the social production of health and disease, or how health and disease are socially produced. And also tropical medicine has this job. Thank you very much, and sorry for this inconvenience. If there are questions, of course, I'll be very happy to discuss with you. Actually, my presentation was meant to provoke discussion and to stimulate. But if you find that what I said is acceptable and you go with it, I'm very happy. It means that we are on the same line. Okay, Valentina.
Thank you very much for your talk. And I want you to tell us about how the public dynamic and what's changed or contributed to change the paradigm of the World Bank model for prevention and care. So somehow the Armada Declaration has come to a new interest, okay? Because the pandemic evolved alone, and so there is a renewed discussion about universal health coverage and universal primary care, which was abandoned for some years. Do you think that's true? And
you know, Valentina, when I came back from Africa, I mean, from my experience abroad, which is Africa, but also in England, I was teaching these kind of things, and I started talking to students, but also in the regional government in Emilia-Romagna region where I live and used to work also, proposing the so-called, first of all, mentioning the Alma Ata Declaration, which nobody knew. But Alma Ata Declaration was exactly saying, which is 1978, is saying how a health sector should be organized to be effective, not just because there is an epidemic. Of course, it will be also more capable to respond to the epidemics, but also in a general day-by-day situation, the health sector should be organized starting from the bottom, investing the excellence which the Lombardy region used to put at the hospitals, should be put at the basic of the pyramid, at the primary care, healthcare level. That's where the excellence should be. And in fact, nobody did this. And what they discovered is that what was missing. Was missing the good, what we call the primary, the cure primarie, sul territorio, the primary care, and we were not prepared. Even the region Emilia-Romagna, which they say is usually far in advance, far ahead in terms of health policy, were a bit weak on that purpose. This was one of the first lesson that we had to learn. The second was that maybe you heard this expression, which is not new, but which came out also because Richard Horton, which is the editor of The Lancet, took it out, dig it out. The COVID-19 was not only an epidemic, a pandemic, was a syndemia, a syndemic. Syndemic meant that was the merge was of two different epidemics, an infectious epidemic, a biological epidemic, and a social epidemic, because most of the deaths were all over the world, were among the poor. And the poor still are those who most suffer from non-communicable diseases, cancer, cardiovascular disease, diabetes, this kind of disease. So are those who were already sick because they were poor with this disease who paid the price, most of the price of COVID-19. So it was a double epidemic, an infectious and a social. And of course, we forgot the social one, and we still concentrate on, we think the vaccine is the answer to everything. I don't believe that. It's important, but we have to take other actions if we want to be able to respond and to survive as a species. So, thank you. Yes, please.
Oh, thank you. When the World Bank started to influence the healthcare sector, what was the role of the WHO? Was there opposition at that time, or did it just sort of happen?
It was a long process. I mean, it started, the first health policy by the World Bank. The first time the bank, the biggest bank in the world, the World Bank, wrote an official policy on health was in 1981, 3 years after the Alma-Ata Declaration, just the time to prepare. They really were scared. All the medical industrial complex, what is called the medical establishment, all the industry corporations, producing also devices, of course, but which, of course, profit from health, from healthcare. Were very scared by the Alma-Ata Declaration because it was a very political declaration. Of course, if you say that the state, the government should take care of the health of the population. If you say that the community participation or the participation of all the population is essential to the organization of health services. If you talk about appropriate technology, this is exactly your field. Appropriate technology is important, is essential again. If all these kind of criteria were completely against the views and the philosophy of the World Bank, of the rich part of the world. So it started on the 80s, 81, then 1993 there was this World Development Report. The World Bank produced a World Development Report every year. And this was the first one in 1993, entirely dedicated to health services. And is a landmark, really, in terms of health policies according to the World Bank, because it says how the health services should be financed, how should be organized, how the hospital, I mentioned already the corporatization of hospitals. The only time I was hired, because during my time at the University of Leeds, I was doing also consultancies for international organizations. I once was asked by the World Bank to join a team. We went to improve the efficiency of the health sector in Nigeria. We went to Lagos, and the first meeting, what I discovered is that our job was to make the public hospitals profitable. Do you know what it means to make public hospital profitable? I hope you can guess that. So I really took the plane. I came back. I thought, really, I can't do that because I don't want to do it from an ethical point of view, but I'm not also capable in like a medical doctor. So that was the point. It was a big revolution in terms of, and also here we experienced that. Probably, I'm sure you don't know, but in 1992, you were still not here in this world. By 1992, the Italian government produced a law which established the aziende. You know, the aziende sanitarie. You know, in Italy, the local health services are called aziende, enterprise. Can you imagine? In 1992, that's when we started also in Italy to follow the World Bank precepts, and that's to me is one also the reasons why we are in this poor situation. But if you want, we can have a lot of discussion out of this, also because maybe it's too sensible for. No, I'm joking, of course. Good.
To make it more argumentative, the whole topic. It's as if healthcare is up to somebody else and not yourself.
No.
That's the kind of impression I'm getting.
Oh, sorry.
Whereas each one has, I think, has to be responsible for his or her health.
Yes, each has its role. Yes, of course. It's not that healthcare is not up to the doctors or to the health professionals. Is that healthcare is up to everybody, and everybody has a role to play in the improvement of health of the population of where you live. Not necessarily, certainly not for everybody, through medical means or medical devices. Okay, but health in all policy. One of you mentioned the health in all policy is one of the strategy proposed. What does it mean, health in all policy? It means that the economic policy, the transport policy, the industrial policy, that the agricultural policies should have, not lead, but at least have health improvement as one of their goals. So everybody has to concur, has to cooperate in the improvement of the health, of our health. So that's the point. That's the message of the Alma Ata Declaration. Of course, the doctor should be a very good doctor. A neurosurgeon should be a very good neurosurgeon, and a public health doctor should be a public health doctor. And a neurosurgeon should be using the appropriate medical devices with the appropriate standards and regulations. But we should move from a monopoly of health by the medical establishment to what the Alma Ata Declaration says, which is, if you have to, actually, there is a lot of references at the end of my presentation, but if there is one which I really recommend, if you want to read just one, is the Alma Ata Declaration, 2 little pages where you find all the basic prescriptions on how to organize health services in a country. So when you work also medical devices, you may have interaction with the policymakers, and keep in mind these indications.
Okay, thank you very much.
Thank you.